Good evening. My name's Keith Heinzman. I'm a community education coordinator for Boulder Community Health. Welcome to tonight's lecture on low-dose radiation therapy for benign conditions. The lecture portion of tonight's program will last about 45 minutes. Afterwards, we'll use the remaining time for questions. Please type your short, general question in the chat box below the video on your screen, and we will take as many as you can. On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers, Dr. Dario Pasalic, and Dr. Patrick Richard. Both of tonight's speakers are board certified in radiation oncology and care for patients at Rocky Mountain Cancer Centers in Boulder. Also this evening, we have the pleasure of a patient of Dr. Richard's, Linda Wanamaker. She'll be joining us. She will tell us about her experience with low-dose radiation. And please, let's welcome tonight's speakers.
Thank you very much, Keith. I wanted to start off by thanking our wonderful partners at Boulder Community Health for inviting us to speak tonight about this really exciting topic with regards to how we approach certain benign conditions with low-dose radiation. So we'll provide a little bit of update on the evidence of how we do this treatment. In terms of the indications for something that is not related to cancer at all, which is why we call it non-malignant. But we find that there's inflammatory conditions throughout various parts of the body that we can potentially use low-dose, non-toxic radiation for. This is who we are, a little bit of our background and where we've trained. And again, we're located here in Boulder at the BCH Foothills campus. A little bit of the outline today. I'll kind of start off by describing what radiation therapy is and how we dose it and how we deliver it. Provide a little bit of an overview of certain musculoskeletal conditions that we're starting to use this treatment for. We're both going to summarize some of the most important trials and data that support the use of this. And then we'll speak broadly about radiation therapy details, how we administer it, what people expect from it, and then our capabilities at our Boulder Rocky Mountain Cancer Center facility. These are some of the objectives. I'm going to start off by, again, identifying non-malignant conditions where radiation can be used. I'm going to start off by talking a little bit about fibrotic conditions called plantar and palmar fibromatosis. I'll transition to Dr. Pasalic, who will explain the osteoarthritis treatment algorithm. And then we'll talk about what this means in terms of toxicity, side effects, and so forth. So it's actually not a new concept at all that we're applying radiation to non-malignant conditions. This is a very long list ranging from meningiomas to Graves' ophthalmopathy, where we can actually use low-dose radiation to help things that are not related to cancer. The predominant part of our practice is treating malignancies, but you can see at the bottom of the list there of the topics that we'll be covering today. So just want to set the stage for, this is a kind of a newer approach that's really taken hold in the United States, but there's quite a bit of experience historically in doing this. This is actually one of the most important slides of the entire presentation, which is the fairly wide spectrum of dose that we use for certain conditions. I think we're most known for dosing kind of on that right side of this spectrum, which are our high doses when we're treating for prostate cancer or breast cancer, and we're actually intending to kill microscopic cancer cells. We have to use higher doses, and that's where a lot of the toxicity comes from, is using those higher doses. But actually, we've had quite a bit of experience using moderate doses, medium doses in that green shade that you see there, what we call 30 gray or 30 units of radiation for cancer pain. So these are kind of lower doses. They're not damaging. There's not a lot of side effects because we're intending to just kind of shrink down the cancer enough to alleviate pain or prevent symptoms from a cancer. But the focus today is on the left side of that graph in the light blue and dark blue. This is very low doses of radiation. We're actually not trying to kill tissue at all. We're trying to change the inflammatory process. And I'll cover in the next slide how we do so. So very different, again, than what most people are accustomed to with radiation, which are the really long, high-dose treatments for cancer. This is very different. In terms of the intermediate doses, we've, again, received grade 1A recommendations. This is our highest level of evidence grade that it's a very appropriate treatment to use for intermediate doses. It's part of our national guidelines. And this is really what we've explored with the low-dose radiation. This kind of set the stage where we don't really need to use high doses for certain situation. And so now we're kind of taking a step further by really trying to de-escalate and use even lower doses for inflammatory benign conditions. This is obviously a busy slide, but a very important schematic to understand of how this actually works. There's a number of steps here, as you can see 7 on this diagram, of how this actually works. So we actually find that these inflammatory cells that surround arthritis or surround plantar fasciitis actually get out of the bloodstream, they get into the tissue, and that's where they start to really cause inflammation and inflammation-associated pain. So one of the first things that actually happens when low-dose radiation is it makes it more difficult for those cells to actually escape out of the bloodstream and then travel into the tissue to cause the side effects. So we actually cause direct damage on the inflammatory cells themselves. And a lot of the inflammation comes from reactive oxygen species, reactive nitrogen oxide species that actually further produce inflammation. So there's actually multiple proposed mechanisms for how these really low-dose radiation treatments change the inflammation in the affected part of the body. One of the most common questions we get is, people hear radiation and they associate that with radiation causes cancer. And some of that is true, but it's actually a very low risk that in that person's lifetime that they receive low-dose radiation, that they're actually at a significant risk of an induced fatal tumor. It's actually very unlikely. There's a number of factors that play into this. Age is always one of our biggest factors. As you can see here, at age 25, there's a 0.2% likelihood of a radiation-induced malignancy. It drops markedly as somebody approaches 50 and then approaches 70. Fortunately, when we talk about some of these inflammatory musculoskeletal conditions, they don't really affect younger patients. So we're often very unlikely to see somebody in their 20s or even 30s, 40s, or 50s. We're mostly seeing 60, 70, 80-year-old patients with these conditions. As I alluded to, the risk is associated with multiple different factors. Age is one of them. The dose we're using, the anatomic location. We find that some of the distal joints, like of the knee, the foot, the ankle, are actually away from all the critical organs that could be induced to develop a cancer. Whereas when we treat things like the shoulder joint, which is near, and the hip, which is near some of the surrounding organs, that risk may be a little bit higher. But fortunately, there's been actually no known reported cases of a secondary malignancy in the patients we've treated for osteoarthritis. So that's comforting to know that the risk is there, we acknowledge it, it's definitely something to be aware of, but not at a high risk. So a little bit about the conditions we're going to talk about today. Osteoarthritis, most people are very familiar with. It's actually one of the most common medical conditions worldwide. Specifically in the United States, we see about 32.5 million cases, mostly of the knee. Next most common is the hip, then the hands. And it's actually, when you look at healthcare expenditures, it's actually the second most common health condition cost-wise in the United States. We'll present some data about how this low-dose radiation can be a more cost-effective solution to this. The fibromatosis conditions essentially is very overactive fibrotic tissue in the palm of the hand or the sole of the feet. I feel it's a pretty under-recognized, underappreciated medical condition that actually affects about 200,000 people in the United States in terms of the plantar fibromatosis, and anywhere from 70,000 to 3.3 million of the hand. Again, these are conditions to be aware of. They're commonly seen in our population. As it pertains to the fibromatosis conditions, we find that a risk factor for it is kind of overuse of the hand. For a number of reasons that aren't completely well known, we find that people that are subject to chronic injury of the palm of the hand or the sole of the feet, so think about runners or people that are really using their hands, are more prone to these conditions. And actually one of the poster childs for palmar fibromatosis is our beloved John Elway. You may have seen him on some of the commercials for this, because of his chronic use of his hand, throwing the football, gripping the football. He's actually developed palmar fibromatosis, and so it's a pretty common condition. This is obviously a busy slide, but what I want to highlight here is kind of the historical treatment for plantar and palmar fibromatosis. What I've highlighted at the very bottom here is historically where radiation has played a role, which is kind of towards the bottom part of this algorithm. It's not often the first thing that people think of. They usually are sent to an orthopedic surgeon that assesses the hand and says, yeah, we can do surgery for this. And whereas some people, as I'll discuss in the next slide, need surgery, one of our key principles here is let's do early intervention if possible. There's a number of conservative things that can be done. You can wear orthotics, you can do rehab, they can inject the hand or the foot with steroids or collagenase, which is a newer treatment. But what we're going to stress today is the importance of early intervention. Radiation for the palm of the hand or the sole of the foot is a very comprehensive treatment. So whereas an injection goes to one of these nodules or cords, radiation treats the entirety of that disease process. So it's a much more thorough treatment often than some of these pinpoint treatments. Again, we want to identify early on who's at risk for this, assess it early. So we often see people that are coming in saying, can you evaluate my hand, the sole of my foot, and see whether this is a good option for me. We actually do have a staging for this to kind of determine who's at highest risk and who could benefit the most from early intervention. There's actually a simple test that we do called a tabletop test. So one of the hallmarks of this is a progressive contraction of the digits of the certain fingers. And so what you simply do is you try to lay your palm flat on the table and kind of measure how flat it can go. Because there's a contracture of the hand, people with more advanced disease really can't put the palm of their hand flat on the table. As you can see in this picture here, it's about a 45-degree angle with the table, and that would put us in kind of a stage 1 category. The early signs of this is when you may kind of feel the palm of your hand. A lot of times you can feel a nodule. You can start to feel these cords that extend down into the palm. And then obviously the digits can start to contract. And what we want to really see people for low-dose radiation for this is the early stage disease. So when we just feel a nodule and there's no contraction, or just feel a cord, or if there's minimal contraction, those are ideal candidates for low-dose radiation. I want to shift into two of the most important studies in this disease category. This is actually a Dutch study. It's called the LEDRAD trial. It's phase 3, so this is kind of a high-level trial, high-level evidence of evaluating low-dose radiation. This is in the foot, so this is a plantar fibromatosis study. And what's really important is that it's blinded, meaning the docs doing this didn't really know who was in what category. And what's equally important is the fact that they deliver what's called sham radiation. This is hard to do a trial like this in the United States. They basically fake the radiation. So half the patients received low-dose treatment. The other half went through the process, and as you can see here, they played a recording of the machine mimicking treatment. So the patients thought they were getting treatment, and the docs didn't know who was in what category. What they were really looking at was pain. Is the pain improved 1 year after low-dose radiation? They looked at a few other things too, like walking ability and toxicity. They used 2 courses of radiation. So typically we do 1 week, separated by about 10 weeks, and then we do a second course of 1 week, and compared that to essentially the placebo. The highlights here are these bottom 2 graphs. The dark green here is complete pain response. This arm here was the fake radiation. This arm here was the actual low-dose radiation. What they found is that there was a significant decrease in the 12-month mean pain score with radiation compared to the sham. And the cumulative pain response was about 75% with radiation compared to a little over 50% with the placebo. So suggesting quite a bit of pain relief with low-dose radiation. Quality of life was improved, as you can imagine, less pain, more function, better quality of life. And you can see that here with the orange bar being higher than the blue bar here. Toxicity wasn't very toxic. We see some skin reaction where there can be a little bit of pink skin changes, a little bit of dryness, perhaps some changes to the nail bed, which we try to prevent and avoid. But what they saw was a little bit of a skin reaction, about a little over 30% with the radiation compared to 18% with the sham radiation. Dr. Siegenschmidt is a German physician, German radiation oncologist, that actually is one of the pioneers of our low-dose radiation. So we very much value his studies. This is a phase 3 trial out of his institution looking at the hand fibrosis. His primary endpoint were who progressed with more fibrosis and who needed surgery. The surgery can be kind of challenging. You have to go in for the operation, they release the cords, you're in a splint, a brace, you can't use the hand. So that's a very valuable thing if we can limit the amount of people that need surgery with radiation. So it was a randomized trial. They looked at a couple different courses of radiation, but what they found was there was a significant reduction in the people who progressed and those that needed surgery, with the radiation being about 20% of people that progressed and 8% needed surgery, versus 62% progressed and 30% needed surgery without the radiation. They again looked at toxicity and saw relatively low rates like we saw in the previous study. And then they didn't see any cancer like we mentioned before. There's a low likelihood of a radiation-induced cancer. So in summary, we see very great efficacy with low-dose radiation to prevent the progression and the symptoms related to fibromatosis. We'll kind of touch this on subsequent slides, but the process is fairly simple. We do a planning session where we kind of map out where we're going to treat. We position the hand under the machine. Again, it's all non-invasive treatment. There's, again, 2 courses. The first course is just 5 days, about a 15-minute appointment, so not here very long. There's no pain or discomfort with these treatments. We see how things go. After about 12 weeks, we'll repeat the same exact second course of treatment. So pretty safe, pretty effective. And at this point, I'll transition to my partner, Dr. Pasalic, to discuss osteoarthritis. Thank you.
Thank you, Dr. Richard, for that great overview. So I'm taking over on osteoarthritis, which is a very common condition that I think many of us are familiar with. It's a clinical diagnosis, meaning we make it based on symptoms. Sometimes we'll do some imaging, which is always nice to have, but not always needed to make the diagnosis. We'll often get some lab work just to rule out other conditions, such as an autoimmune or immune-related arthritis, such as rheumatoid arthritis or ankylosing spondylitis, because those conditions, are treated very differently than osteoarthritis. But once we have that diagnosis, there's a lot of different treatments that we can go with. We start off with conservative measures such as weight loss, physical therapy, and then we move up this ladder on this pyramid, such as topical NSAIDs, topical therapies, injections, and then ultimately surgery when there's something like bone-on-bone that requires a surgical intervention. So where does radiation fit into all of this? Well, ideally we want to try and get to patients when they're in that middle, early to mid-disease course. They've tried some conservative measures such as physical therapy and weight loss, topical pain relievers, but they're not so advanced that they need surgery because that's a very different condition at that point. We want to catch patients when they require things like injections or oral medications to help with their pain. And that's exactly where radiation fits in right now. So we've actually been treating osteoarthritis for over 100 years. The first treatments were done in the early 1900s, but it fell out of favor over the years, particularly in the 1980s, 1970s, as we gained more effective pharmacologic agents, oral medications and topical agents. And there were also some negative trials that I'll talk about as well. Some surveys of physician treatment trends showed that in the US, we really stopped using radiation for osteoarthritis, but in Europe they continued this treatment course and they gathered more and more data over the years, which was really, really nice to be able to show that effectiveness. As I mentioned, there were some negative trials in the 1970s, but they had a lot of limitations. Many of these trials included not just osteoarthritis, but as I mentioned, immune-related conditions such as rheumatoid arthritis or ankylosing spondylitis. And when you mix in those different conditions, sometimes you can't really tease out what's effective, especially from a radiation standpoint. They also didn't use the modern low doses of radiation therapy. They used much higher doses, which can come with higher side effects and maybe not as high of an efficacy. And of course, they didn't use more modern radiation approaches where we have smaller fields, more focused, to again minimize side effects and maximize the effectiveness. Again, thankfully, the Europeans continued a lot of this work, particularly in Germany, where there's been a cooperative group collecting a lot of this data over the years. The most recent update in 2018 showed different levels of recommendation for the use of radiation for benign conditions. And overall, what the data showed was about a 60 to 90% symptomatic pain relief with the use of low-dose radiation, with essentially no side effects that I'll get to in a minute. But here's that overview. This is from that review committee summarizing the evidence. The highest level of evidence seems to be for the use of low-dose radiation in the setting of knee osteoarthritis, elbow osteoarthritis, and even other conditions that we haven't touched on tonight, such as plantar fasciitis, which is somewhat similar to the approach that Dr. Richard mentioned for plantar or fibromatosis. There's still some good evidence for other anatomic areas, such as the hip, the hand, the ankle, the shoulder, but we just don't have as much in-depth evidence as we do some of these other anatomic locations. Again, from this review, we see that this is a very effective treatment, and out of the over 1,000 patients that have been collected in many of these studies, there's only been one side effect, and it was a mild case of skin irritation. So very effective with limited side effects. We now have really good modern data as well. This study was actually just presented recently, 2025. It was a randomized phase 3 trial, again, kind of the tippy top of our evidence hierarchy, where this trial only enrolled patients with knee osteoarthritis and randomized them, so they flipped a coin. A third got sham radiation, so they pretended to do radiation. A third got an ultra low dose of radiation, and the other third got the low dose of radiation that we typically use for our patients. And they followed these patients, and they looked at the 4-month pain outcomes, and they showed that with radiation, the actual treatment that we normally use, there was a reduction in pain of about 70% compared to the sham radiation group, which was 42% at that 4-month mark. And there's a clinically meaningful improvement in pain index in that radiation treatment arm, 57% versus 31%. So again, very good evidence that this is an effective treatment, and we'll continue to see what this trial shows as we follow these patients further. Other studies from Europe have demonstrated similar results. This is another study looking at knee osteoarthritis. Instead of having sham radiation, they used oral therapies such as glucosamine and chondroitin versus doing that same oral therapy plus the low-dose radiation. They followed patients on looking at pain and functionality and disability, and this is what they found. There was an increase in quality of life, even at long term, 1 to 3 years in terms of giving radiation versus not giving radiation. The nice thing about this study is that they could also look at the disability rates of patients long term, and they found that with low-dose radiation, there was a lower rate of disability or use of disability services. There's a lower rate of surgeries, so less patients were requiring knee arthroplasty. And also surprisingly, that serial MRI changes showed actually improvement in cartilage thickness, less bone marrow edema, and less articular surface thinning, showing that there are some bony and articular and cartilaginous cartilage changes that seem to happen with low-dose radiation long term. Some other studies looking at other anatomic areas, including the hands, comes from this Alvarez study. It was a prospective study, so not randomized like the other studies that I mentioned, but it was mostly confined to patients with osteoarthritis in the hands. And it also showed a reduction in pain, 94% at 3 months, 6 months, 12 months. The median pain score before treatment was an 8. After treatment, it went down to 5. About 2/3 of patients showed an improvement in functionality, so better use of their hands. And some did require a second course of radiation, and we'll talk about that, where we start off with our initial course, we give it 3 months, reassess, and those patients who didn't have as great of a response, we can do another course, and that usually tends to lead to higher response rates. And also, no complications in this study. Another study, the Dunn-Auber study, looked at many different anatomic areas, not just the hands or the knees, and they also used low-dose radiation. And again, similar outcomes, reduction in the general pain, a mean score of 6.5 to a 3.8, reduction in load-bearing pain, and morning stiffness pain. So very consistent with the other studies. We're really excited. There's more randomized studies that are currently underway from Germany, from Spain. The one I just mentioned was presented from Korea as well. So really, really exciting. And it's not just us that are offering these treatments. You know, other major institutions, Cleveland Clinic, City of Hope, UCLA, University of Pennsylvania, University of Pittsburgh, even our colleagues up north at Banner, we're all engaging our community members to give this treatment a chance, because it can really improve outcomes, both functional, pain, and quality of life. So we're really proud to offer this treatment closer to home to our community members. You know, radiation therapy can sometimes be intimidating. This is what many of our machines look like. It looks like something out of a Star Wars universe, but you know, it's very safe, very effective. We've had, you know, 20, 30, 40, 50 years of experience at our different sites. And we know our technology is safe, effective, and we're able to address anything that comes through our door. You know, every patient is different. Everyone has a different need. You know, they have different abilities to move their hands or their knees or their legs. And so everyone's setup has to be a little bit different. And what we have to ensure as radiation oncologists is that, you know, the area that I'm treating is going to be set up precisely each day. There's very minimal chances of error, of problems occurring. So the way we do that is we want to immobilize each of the areas that we're treating. So for the hands, we make special masks, special fitted devices that lock those hands in place so that when we give the radiation, there's not much wiggle room. So here's an example of, you know, when we make a mask for the hands. For the feet, we'll make these custom, molds for the feet to immobilize them. For the knees, we'll also make these devices, almost like a little bean bag that molds around your legs or your shoulders to, ensure that you're in the exact same position each day. We've got a lot of convenient locations for our community members in Aurora, in Boulder, in Littleton, and Thornton to allow us to cover a really wide area of coverage for our patients and their family members. So in summary, low-dose radiation can be used for a variety of inflammatory conditions, including osteoarthritis, palmar fibromatosis, plantar fibromatosis. Some other things we haven't mentioned tonight are tendinitis. Plantar fasciitis also has a lot of good evidence. These are all based on phase 3, phase 2 clinical trials, which are kind of the epitome of evidence in modern medical trials. Treatments are minimally invasive. There's no injections, no changes in your routine. Patients continue to work, to hike, bike, exercise, continue on your medications, no changes there. The treatment sessions are pretty short. You know, for osteoarthritis, somewhere as low as 6 sessions, sometimes as high as 12 sessions. You have to do a repeat course. They're very convenient, about 15 to 20 minutes per radiation session. We have, like I said, 4 radiation oncology locations throughout the metro area. There's minimal side effects. Out of the over 1,000 patients reviewed in those trials, 1 patient had a skin redness event for osteoarthritis. So a very, very low rate of side effects. You know, we consider patients who are early to mid disease course. For example, for the palmar fibromatosis, again, we want to find patients who have cords, who have nodules with minimal contracture. The more contracture that you have, we can certainly still do radiation, it's just not as effective. Same thing with osteoarthritis. We want to try and find patients who are early to mid disease course, not when things are severe and you have bone on bone and require surgery. Ideally, for osteoarthritis, we look for disease sites with large joints out of critical areas. So that's the knee, that's the elbow, the shoulder. Things such as the spine are a little bit more complicated. It's oftentimes not just osteoarthritis in the spine. There's many other things. There's disc problems and stenosis and a lot of other more complicated pathophysiology. So the spine is a little bit more tricky to treat, but again, we're happy to meet with all of our patients in person to talk about their condition and figure out what suits them best. And also, we want to make sure that we're treating patients, typically older than age 40, age 50, again, to minimize that theoretical risk of a secondary malignancy to as low as possible. I'll have Dr. Richard come back up. Thank you.
Thank you, Dr. Pasalic, for a great overview of what we've been able to accomplish with osteoarthritis. So without further ado, I'm very honored to introduce our guest speaker tonight, Ms. Linda Wanamaker. She was a patient of mine earlier this year, and she's been gracious enough to volunteer her time this evening to share her experience going through this. So yeah, I want to welcome Linda up and let her share her story.
Good evening. I first met Dr. Richard at BCH when I accompanied a friend who was starting radiation treatment for breast cancer. I saw information in a bulletin in the treatment room about low-dose radiation and learned that it reduces inflammation. I asked about the process, and then I spoke to Dr. Richard about my knee problems. He was very informative and answered all my questions. It was decided that I was a candidate for this treatment. Before starting radiation, I went into BCH to get final measurements, equipment setup, and table setup. 2 technicians explained everything to me. They answered all my questions, and they were very efficient. They made sure I was very comfortable during this whole process. I started treatments on January 7th, 2025, going 2 times per week for 4 weeks for a total of 8 treatments. Each visit started always on time. The table was set up and ready for me. I did not have to undress, and as soon as I settled on the table, the radiation treatment started. I was amazed at the equipment. This large radiation machine seemed to have a mind of its own. It went wherever it was supposed to go, based on the treatment and the measurements they had put into the machine. It was a fairly short procedure, and before I knew it, I was heading home. My last treatment was on January 29th, 2025, and when I saw Dr. Richard that day, I was able to tell him that the day before, I had taken a 2-hour walking tour of Amazon Fulfillment Center near Broomfield. I also climbed 2 flights of stairs. This was something I could not have done before the process. Throughout the process, I always felt safe, informed, and well cared for, and it was the best thing I did for myself. Thank you.
Thank you, Ms. Wanamaker. We have some time for some questions. Doctors, is there any surgical outcome data on patients who receive the radiation treatment? In other words, does the radiation potentially complicate surgery if patients eventually need it?
So, I'm not aware of any prospective, randomized data in this space, but we'll often do radiation before surgery for other conditions. Specifically, there's something called heterotopic ossifications that can happen where some patients, when they undergo surgery, they have a really brisk reaction to, before they undergo, when they undergo surgery, they have a brisk reaction in terms of their muscles producing calcifications and such. And when we give radiation, it can minimize that from happening. And, we tend to do that fairly commonly in our orthopedic patient population, and it does not seem to lead to any increased rates of complications with the surgery. We tend to do the radiation, sometimes before the surgery or sometimes the day after surgery. So in that space, and by the way, those are much higher doses that we use as well, there's really no increased complication rates. The low dose radiation rates, the low dose radiation doses that we're using here really should have no or minimal impact, as far as I'm aware, with surgery.
Yeah, and it's an excellent question because it's something that, as we presented this data and information to some of our surgical colleagues, whether it's a hand surgery or hand surgeon or a knee or hip orthopedic surgeon, that's actually one of their most common questions is, what is this expected to do if 2 years down the line the pain starts to come back and I need to replace a joint? Will this have implications for me? And the short answer is no. I would agree. There's not a lot of studies evaluating that. But again, we can't emphasize enough how low this is compared to the higher doses we use where it could have implications for surgery. There would be no suggestion of that. And in that Segan-Schmidt palmar fibromatosis study, a handful of patients did need surgery after radiation. It was about 8%. They didn't see any significant complications in those that needed. This suggests it's reasonable to do even knowing that surgery could be necessary in the future. So really good question.
Excellent. Thank you for that information. Do you have any experience treating Ehlers-Danlos patients with this strategy?
No. That's a good question. That's not really an inflammatory condition. So I wouldn't expect that, the pathophysiology behind that Ehlers-Danlos syndrome, which is when some of the connective tissue and ligaments they're kind of overstretchy, and we see some downstream consequences of that. I wouldn't expect this to really play a role unless there was a secondary arthritis because of a joint that's under a lot of tension or stress or so forth. But anything to add to that? Yeah.
No, that's a good summary.
What overall health issues would prevent someone from having this treatment?
Nothing, frankly. Patients, we treat patients all the time with active cancer who have many more active medical conditions. They're on blood thinners, they've had a history of stroke, heart attack, they're on multiple different medications, they're on chemotherapy, and we give higher doses of radiation, and those patients do incredibly well. Again, this is even lower doses of radiation, has no impact on your day-to-day life. You can continue all your medications. The main limiting factor is being able to come in, transportation, mobility issues. We can help with that. Our center has social workers that can assist with that. So we have resources in place. So it's more of a social, I would say, limitations as opposed to medical limitations for this treatment.
Yeah, and I would completely agree. This is very different than our typical cancer patient, where they can come in with a lot of pre-existing health issues that factor into the decision. Common things that come up are blood thinners. I'm on anticoagulation. That really pertains to surgery, so that's often a more complicated factor for surgery, where you have to get yourself off the blood thinners and do surgery. With radiation, again, one of the biggest benefits we have is non-invasive. We don't have to factor in the blood thinners, the other cardiac clearance or lung clearance. I would say the vast majority of people are healthy and well enough to undergo these low-dose treatments.
To To continue with that line of thinking, you mentioned small likelihood in incidences of cancer after treatment, but what about secondary damage to nearby tissue?
Yeah, so I mean, another excellent question. It's something that we cover in the initial visit with these potential patients. Again, one of the benefits is one of the most common things we see is knee osteoarthritis, like what Ms. Wanamaker shared with us. There's really no organs around there, so that's first and foremost. We find that certain tissues, certain organs have sensitivity to radiation. A knee, an ankle, a foot, there's really no critical organs around there that we worry about. As we showed in some of the studies, the skin can get mildly irritated, and that's pretty unlikely too. The vast majority of people really don't have a lot of appreciable side effects. Some of the folks I've treated with this will report a little bit of fatigue with certain activities. But again, we want you to continue doing your activity, doing your daily living, and not really having to consider limiting anything as you go through these treatments.
Okay. Another question for you. If one is diagnosed with osteoarthritis and rheumatoid arthritis, can the osteoarthritis be treated with low-dose radiation?
Yeah, this becomes more and more complex as we start putting layers on top of things. It's really hard sometimes to tease out what's osteoarthritis, what's rheumatoid arthritis driven. That mixed picture does complicate things. It kind of gets into the weeds a little bit, which is why I always encourage folks to come see us so we can, evaluate each case on a case-by-case basis. But I do worry that, maybe the predominant issue is the rheumatoid arthritis, and that the osteoarthritis can sometimes be a minor component. And being able to differentiate between those two is often a clinical and imaging diagnosis. So it requires, I think, a keen inspection of all the details of all the prior imaging, lab work, and trying to figure out what might work in this case. What are your thoughts, Dr. Richard?
Yeah, no, I would agree, and actually I'll give an example of somebody I saw today for knee and big toe arthritis. And as I started to kind of explore these approaches with him, it was understood that he actually had gout of his big toe that probably secondarily caused so much inflammation over his years. Gout was under control, but it had secondarily caused bone-on-bone situation down in his big toe. So, it does become a little bit more complex, and not as complex, but my discussion with this gentleman was, you have gout. Radiation's not used for gout, but potentially could help the underlying arthritis. And maybe I think this is where this question is coming from. Is we see a lot of other inflammatory conditions which we didn't cover today, which theoretically may be of benefit. But this is part of the discussion. What is the risk? What is the benefit? Risks are not very high. In the case of rheumatoid arthritis or gout, the benefit may not be as high, but we decide together whether we want to do that or not. So I think that's where, hopefully we'll be seeing some of the evidence and trials conducted is in some of these more complicated situations like gout or rheumatoid arthritis. And as Dr. Pasalic mentioned, the spine can be a little bit complicated with other things going on. What is the role for low-dose radiation there? And secondarily, we actually presented earlier today to our primary care physicians here in Boulder, and that was the question that came up. She basically asked, what is the harm? What is the risk of just trying this and seeing if it would benefit somebody, just to reduce the pain? And again, not saying we would rush into any of this, but that's why I would just encourage, those with these type of questions, more complicated joint situations, just come and see us. We're happy to spend time with you to really determine, is this going to be effective? We don't want to, particularly for arthritis, like Dr. Pasalic mentioned, we don't want to rush into it. It's not like you wake up and in pain and next thing you know, you're getting radiation. We want to really evaluate where we may play a role and what's going on so that we're best selecting people to get the benefit.
Are these treatments covered by insurance or Medicare?
Absolutely. We've had no issues getting this approved. We have an entire, prior authorization team. We have a financial counseling team as well that will give you cost estimates and co-pays. Have not run into any issues from an insurance company standpoint.
Yeah, we believe it to be a cost-effective treatment, as I alluded to in the previous slides. Yes, we're always running into insurance issues of some sort, but fortunately it doesn't really apply to this. We get more of that on our cancer side of things than we have with this. And I've pretty much treated people with commercial insurers and Medicare. It's all covered. They see it as a cost-effective solution, and yeah, we're blessed that that's the case. It's not really a long, drawn-out battle like we experience with other situations. So that's an excellent question.
And I believe you covered this, but I'm sure everyone worries about it. What does the recovery look like with this therapy?
Really minimal. The worst case scenario I would say would be you have some fatigue, some tiredness, not a debilitating fatigue, more like a have to take an extra nap, go to bed early kind of fatigue, and even that is kind of a rare side effect at these low doses. Again, skin irritation could be a potential. The recovery time for those, we're talking about 2 to 4 weeks at the most, and not, life limiting in any way, I would say.
I saw Linda over here on the side shaking her head saying that, there was no recovery. And if you listen to her testimony, she said right before her last day of radiation, meaning there was no recovery. She was off doing the Amazon tour, and there wasn't much recovery needed after, as she was just progressively getting better. So yeah, I mean, an excellent question. Definitely one that comes up, but again, we want people to kind of, not overuse the joint, but test it out. I treated a woman last month for hand arthritis, actually at the wrist joint, both hands. And every week I saw her, I said, how's it going? What are you doing? And she was out gardening and doing yoga and doing poses and kind of putting it to the test and doing quite well. So we don't feel that, again, we're doing this to improve function. So let's continue to do that even during and shortly after treatment.
Okay, thank you. This question is about 2 different conditions. Is this viable for Morton's neuroma? And then also, could a hernia be treated like this?
I would not use this to address either one of those conditions.
I would agree, yeah. I mean, again, different, when we look at this compared to other health conditions, really it comes down to, is there inflammation? Yes, if a hernia was really bad, there may be surrounding inflammation, but wouldn't use it for that. Morton's neuroma, again, different. There could be secondary inflammation, but again, I would agree. Until more data comes out and maybe we investigate this, I would probably hold off on those 2 conditions.
I have a question specifically about coming from Austin, Texas. Are there any other clinics in the U.S. that are also using these treatments?
Yeah, as I mentioned, there's a lot of larger academic tertiary sites that are already offering this treatment. Coming from Austin, Texas, we have we're part of the U.S. Oncology Network. Texas Oncology is one of our partners in Texas, and I'm certain that they offer this treatment for their patients. So, if you look up any radiation oncology center and look into osteoarthritis, I would guess that many are starting to offer it nowadays. Now, it's a slow process, not every center, so definitely do your homework, do your research, but it's becoming more and more of a mainstream treatment.
What is the level of radiation dose when comparing to regular X-ray versus the indications being presented?
Yeah, so this kind of goes back to the slide I initially presented with that pretty wide spectrum of radiation dose. We're trying to back up to that slide so you can see. So we're talking, as you can see here, osteoarthritis is 3 to 4 units of radiation. GY stands for gray. It's just a measure of absorbed radiation dose. We're using megavoltage X-rays for this, whether it's 3 to 4 gray or 80 gray for prostate cancer. But you can see, how much of a magnitude of difference this is going from, the far right of that spectrum in the orange and red, 70 to 80 units of radiation, which of course carries with it more potential for side effects, and how 3 to 4 units, I often describe it as a whiff of radiation compared to what we use for malignancy. So it sounds like the person who asked this question has maybe a background in science or physics. We can certainly get into more details about the machinery and the energy. Generally, we're using megavoltage X-rays on that electromagnetic spectrum, kind of on the far end of it. So it is still in that spectrum, which is what we use. But that's doesn't relate to the dose. The key here is, even though we're using high potency energy, the dose is very low.
Are there studies on the use of low dose radiation on the hip?
Yes, not as robust as some of the studies in knee and plantar and these other anatomic locations. We tend to extrapolate to some of those larger joints based on that data. There are some prospective and retrospective studies. Again, that data is not as good as a phase 3 randomized trial. And again, as we get into some larger joints, like if we're talking about the spine or the hip, there's other conditions that we have to be aware of. That it's not just osteoarthritis. We have to worry about other issues like bursitis, and muscle atrophy and other conditions. So there's a lot of other things that could go wrong in certain anatomic areas that we have to be considerate of before we jump to the conclusion that it's osteoarthritis. And so those areas may not see as much of a benefit with radiation, especially if those patients aren't selected very carefully and very appropriately. So I'd say there is a benefit. There is evidence for a hip, but not as high of a degree of evidence as the knee or elbow or other anatomic sites.
Yeah, and I would agree with that. And when it becomes, a question to us as to are there other things underlying the arthritis or around the arthritis, I would say those are the folks that we do kind of work up a little bit more. Maybe we get some X-rays or an MRI. Just again, we want to make sure we're selecting this for the right people and that we, have the highest degree of confidence that we're going to help you. And that's the kind of the big overarching point to make with spine and hip and some areas where you get more complicated pathology. You just quite don't know what to expect there. So we may do things that image and kind of assess things. I'm about to treat a guy that does have some arthritis. There's some tendinopathy, kind of the gluteal tendon. So this was part of the discussion. I said, you have some arthritis. There's these other things which radiation probably will help with, but I agree, we just don't have. And it's going to come. It's just we start with the knee because it's the most common, but I have treated some hips. I've had pretty good success with it. So individual basis, come and see us. We can kind of work through what we may need to do to evaluate things before we get started.
To continue on that idea, for osteoarthritis of the hand, does one need a referral from a rheumatologist before seeing you after PT hasn't worked well enough?
Not specifically from the rheumatologist, but we do need a referral. So usually we actually can just get you scheduled, and then what we do is reach out to your primary care doc or whoever has routine follow-up with you and tell them what we're going to do and that you're a good candidate for it, and then they usually send a referral. We haven't had any issues with getting referrals for it, but it is required, and we kind of take it upon ourselves to reach out to your doc and get their approval and their referral.
Yeah, and I really like it when we get referrals from rheumatologists, because oftentimes you've gone through the gauntlet of a pretty extensive workup to make sure that we rule out other immune-related problems, rheumatoid arthritis and other things that I mentioned. So it's really nice to have some of that lab work, some of that data. Not everyone comes with that, which is okay. But when we do see it, it gives us more confidence. Yeah, we're pretty sure that we're dealing with an osteoarthritis here. that the treatment, if we can find the area that's causing the most trouble, we can be very effective in our treatment approach.
And often it's helpful to get a referral, even from physical therapy. I mean, we've seen, as we've kind of shown that pyramid of, where radiation fits, most people have done physical therapy and exhausted those options. And so, yeah, it's good to get a referral we've gotten referrals from podiatry for the foot, physical therapy, chiropractors, primary care, orthopedic. So there's a number of specialties that often are kind of involved in your care that, we can get the referral from, so.
It looks like we have a time for a few more questions. When you speak of hand arthritis, can this help pain in the thumb joint area?
Absolutely. So I just alluded to a patient that I just treated. It wasn't so much kind of in the distal joint, but it was actually along where the thumb joins the wrist, which is often used in grip. But we can treat any joint, and Dr. Pasalic showed a kind of a slide of how we isolate that joint. So in that situation, we would kind of get the thumb off to the side so that we're treating. He's showing a nice picture there of how that would look. We're kind of just using a smaller field of radiation that really just isolates the thumb joint. We want to avoid the other fingers and other parts of the hand if we can. So, have treated the thumb, and you just done some hands recently too.
Yep, bilateral hands.
Yep. So really the principle, and I treated a guy's foot, and it was just kind of a pain along the sole, along the big toe. So we kind of created a field that was personalized to him that avoided the rest of his foot. So yeah, it's pretty. I mean, that we're known for precision, we're known for accuracy, and we can isolate even very tiny parts of a joint or hand or finger.
Would this help with inflamed scar tissue that never healed from joint replacement surgery, specifically big toe joint?
That's a little bit of a complicated question. We'll often use radiation for keloids, which is kind of overactive scar tissue. That's usually in conjunction with surgery and then doing radiation to prevent additional scar tissue from forming. What you're describing, makes me worry. Could there be? Is this an open wound? Is this, what exactly are we dealing with? What are your thoughts, Dr. Richard?
Yeah, I mean, I would agree. In a post-surgical case like this, again, we work hand in hand with your previous doctor, your surgeon, whoever's been a part of your care to help us understand what's going on there. It's being described in the question as an inflamed bit of scar tissue. Again, we want to assess what that looks like, work with your surgeon to kind of understand it before going after it. But theoretically, I mean, this helps with inflammation. If we have a firm, grasp on what's going on in that joint and what complications there were from surgery, could be considered, but we need a pretty thorough discussion with the surgeon here about what's going on before proceeding.
Can it be used on the shoulder if a patient has a pacemaker?
Yes. It kind of depends on the proximity of the pacemaker. Really not worried about the leads. So the leads are not that sensitive. You're really worried about the hardware. So the actual bulk of the pacemaker device, the hardware, the chips that are in there. We deal with this all the time with our radiation treatments for cancer. These fields can really avoid the pacemaker altogether, but again, it's a case-by-case basis. I really have to know sort of where that pacemaker is located on the chest in relation to the shoulder joint. Really nuanced, really involved discussion.
Yeah, and I would agree. We have a very extensive protocol we have for pacemakers. Oftentimes they're away from the shoulder joint, so I do feel that we could avoid it by kind of angling the beams in a way to avoid it. We work with your cardiologist to understand the pacemaker, when it was placed, kind of the details of it. We get all those records, and then again, typically for a shoulder joint, we likely could avoid it, making it very unlikely to damage that device, and we'll keep it functional.
Well, thank you so much for all the information. We've come to the end of our time. To our speakers, is there anything else that you'd like to say before we end tonight?
Not specifically. I think we covered, the good basics of what we offer here. We very much appreciate your time. I think there's some details on the slides about how to contact us, and it's a pretty easy process getting in to see us. So, we look forward to the opportunity to work with you if possible. So, again, thank you for your time.
A recording of tonight's lecture will be available at bch.org/livestream. You will receive a post-lecture survey and link to the recording by email. Please take a minute to fill out the survey. Thank you for joining us and have a good night. Thank you, doctors.